First of all, I'd like to ask everybody to please make sure that your microphones are muted, and we will let you know when to unmute them. We'll have questions and answers at the end. First off, I want to thank everybody for taking time out of their afternoon today to attend this. I think it's an important topic. We're doing these workshops, community conversations, on a roughly bi-weekly basis, although I do want to give everybody a heads up that an invitation will be going out after this one for next Thursday, the 3rd, when we have an epidemiologist from UConn who will be coming to answer general COVID-related questions. Today, we're fortunate enough to have a pharmacist, so we're going to approach it from that point of view, the medication side of things. If you have questions that you want asked, it will be easier if you can type them into the chat box, which, wait, let me back up for a second and tell you a little bit about the Connecticut Center, because I actually have a slide about the chat box. We were established in 2004 by residents who believed that patients should have the right and should expect to receive safe, high quality health care. And we wanted to make sure that patients had a voice. So we were organized into a nonprofit to address the needs and expectations of individuals who are getting healthcare in our system. Since then, we've grown tremendously and changed, and we're now doing a lot of work to educate patients, which we firmly believe is the best way to get healthcare to change in conjunction with other things. So at any rate, during this workshop, community conversation, if you want to chat, there's a control bar, and down at the bottom right here in the middle is a chat icon. Click on that, you'll get a chat box to the right, and then you can type in your messages. If you want to change your screen view to see one person, the person who's talking, everybody who's in attendance, whatever, you can go to the upper right-hand corner and you will see little icons there, and that will allow you to change your view. If you want to raise your hand, go into the participants window, which is indicated by the arrows on the control bar, and next to your name, there should be a raise hand icon. If there's not, I don't know quite what to tell you, except that you can type something into the chat box, or you can, well, you can type something into the chat box would be the best thing. I want to thank you all for coming. I want to thank Lax Pudipeddi, the pharmacist that we've invited and are fortunate enough to have here. And I want to mention that we are recording this. It will be used for educational and promotional purposes. So if you don't want to be recorded, please disconnect yourself. And then you can always view it afterwards. But we'd hope that you will stay on and be part of this really important community conversation. So with that, I am going to turn it over to Nilda, who is our community outreach coordinator. And this is our information. You can reach out to us through the email that you have gotten through the registration process and get further information from us if you need it. We will send out some kind of written summary or documentation of what took place. And with that, Nilda, it's all yours.
Thank you. Thank you, Lisa. You're welcome, everybody. It's my pleasure this afternoon to present Lax Pudipeddi, the pharmacy manager and co-owner of Bridgeport Pharmacy. He has been practicing pharmacy since 2004 and has his bachelor degree in pharmacy from India and a master in computer information system from New Jersey Institute of Technology, Newark, New Jersey. He had the privilege of doing his pharmacy internship under the mentorship of two independent community pharmacists who owned the store for over 40 years. He learned right away the art of practicing community pharmacy. He's also an immunization certified pharmacist, naloxone dispensing pharmacist, anticoagulation management certified pharmacist, and a member of the American Association of HIV Pharmacists. He started Bridgeport Pharmacy in 2008 and East Main Street. And since he's been serving the clients of Bridgeport metro area, he loved being part of the community and serving the people, and he loved everything he does. Welcome, Lex, and we are turning over to you. Thank you.
Okay, Lax, I just have to really quickly turn control of the screen to you. I'm sorry it didn't go the way I thought it would. But we will quickly give Lax control. Bear with me. Sorry, this is the first time we're doing it with a remote speaker with a video with PowerPoint. And again, totally apologize here. Something had to go wrong, of course. I'm really sorry, guys. Lax, could you perhaps just jump in and share a little bit? Oh, darn it. I had it for a second. Can you share a little bit about what you're going to talk about? And maybe start, and I'll get you hooked up in a second.
Sure. Okay. Hello, good afternoon, everyone. Thank you, one and all. If I say the names, it'll be a long time because I appreciate the fact that so many people turned out for this presentation. I truly appreciate that. And as Nilda and Lisa have mentioned, my name is Lax Pudipeddi. I'm a pharmacist and a pharmacy manager of Bridgeport Pharmacy on East Main Street here in Bridgeport. And as Nilda said, I've been practicing the pharmacist profession since 2004. I've been a pharmacist. I worked for the companies like Rite Aid, Walgreens, and other places. And in 2008, I decided I want to be a part of the community pharmacy as opposed to be stuck in a box. So with my friend of mine, we opened up Bridgeport Pharmacy on East Main Street, right next to the Bridgeport Community Health Center, which is called Optimus. And since then, I'm blessed to be a part of the community. And as I always say, I love what I do. It's very rarely you get an opportunity to do what you want to do. And in my case, I'm able to do what I want to do. And that's it. I've been in Bridgeport since 2008, and so far so good. So with that being said, whenever Lisa gives me a green signal, I will go ahead and start my presentation. Obviously, we are living in a very crazy times, so obviously we will see some glitches here and there, and pardon us for that. But nonetheless, we'll try to make it as seamless as possible.
Okay, I think I have found out what I have to do, and I apologize again. Bear with me. I just need to get back to the video. Oh, this is,
Lisa, let me try to share my screen and see if that makes, let me see if it works.
yeah, see if you can. Yes.
You can see my screen?
Yes. Can everybody see the screen?
Give me a yay or nay, so I know exactly.
Yes. Yes.
Okay, then you're good.
Okay, wonderful.
Perfect. Thank you.
Thank you very much.
You're welcome. You're welcome. So with that, let me start. Hopefully, I don't encounter any issues. So here we go. Once again, thank you, Lisa and Nilda, for this opportunity and in hosting this Connecticut Center for Patient Safety and the challenge the whole world is facing today is the dreaded word, the COVID-19. Um, it's unfortunately true, but the one thing that brought the whole world together and has socially distanced every one of us is COVID-19. We are living in a pandemic which none of us have experienced in our lifetime. The only pandemic we always hear is the Spanish flu in the early 1920s. And back in 2020, we see this pandemic, the coronavirus or COVID-19. So with that, let me first start. Obviously, any presentation always has this fine print where I have to mention that there's absolutely no conflict of interest in my presentation, other than that we are having a peer-to-peer discussion or conversation about the pandemic we are in right now. And I would like to emphasize the fact that I have not received any compensation other than, us working together and to benefit what we learn in the process to take care of the ones we love and we care. I'm sure all of us have some degree of knowledge from watching TV or reading something or listening to something what a COVID or coronavirus is. Coronavirus belongs to a class of the viruses which cause the common cold. And that's why it mimics pretty much a lot of symptoms you see in a common cold. However, in a more diabolical way. The CDC, which is the Centers for Disease Control, has estimated that the severe acute respiratory syndrome, also known as SARS, the COVID-2, has been in the community since late January to early February, because there were cases which were unknown, undiagnosed, or unnotified, where people were experiencing flu-like symptoms or tightness in the chest or breathing, all these problems which could be seen from COVID. And they've been seeing doctors and nobody could pinpointly say this was coronavirus or COVID-19. They were like, it's a viral infection. They used to give medications. And I myself and my family members have gone through where the doctor said it was not flu, it was not strep, it was not anything but something viral. So it's been around since late January and early February. What makes this virus really, in a very bad way, interesting is it can have absolutely no symptoms, which is asymptomatic, to mild symptoms where people could have simple fever, chills, a little bit of fatigue, and that's it. And it could go as severe as having severe pneumonia or something called as ARDS, acute respiratory distress syndrome, where the breathing becomes really heavy and people are unable to breathe on their own and have to be on a physical means to provide the breathing. This is, as I said, it's a novel version of the coronavirus, which has changed itself and looks like a common cold with flu-like symptoms, but could end up having a much deadlier outcomes, unfortunately. And this particular virus does not discriminate as to who you are, what you are, where you're from. Anybody can have mild symptoms to severe symptoms. We have seen the royal family in UK got infected, and as much as the wife of the prime minister of Canada. So it doesn't discriminate. Anybody can get it, and the common thing which they are seeing is with regards to the blood types. What kind of blood types are more susceptible? What kind of patients with different kinds of comorbidities are more susceptible? The younger population are able to fight it off without much of an issue. But although there are few cases where younger population have been hospitalized, people with underlying conditions tend to have further more severe symptoms and severe outcomes as opposed to people with no pre-existing conditions. So especially in the population which I deal in Bridgeport, we have seen substantially higher severe infections and hospitalizations in people in the patients and patients with diabetes, any heart issues or heart problems, hypertension, and other comorbidities. We all know the symptoms of COVID-19 or coronavirus. Everybody has been talking about it. Everybody says, oh, you have a cough, fever, you have it. The CDC and the WHO have been adjusting these symptoms on a regular basis to see as and how more and more people are getting infected. They're learning how these symptoms are presenting themselves in patients. Generally, there was a recent study which I came through, said initially they're seeing predominantly in the symptomatic patients. Asymptomatic patients are ones which do not have any symptoms. They are the carriers, but they don't have any symptoms. The symptomatic patients are the ones who tend to have fever initially and then have these secondary symptoms such as fatigue. Obviously, with the fever, you get the fatigue. With the fatigue, it progresses to sore throat, headache, congestion. There have been a lot of information about the nausea, vomiting, which is considered as a GI symptoms, which are gastrointestinal, like nausea and vomiting and diarrhea. And when it presents in this some sort of an order or disorderly order, you can pretty much know that something is not right. And the very bad part about this is all these symptoms mimic a flu-like symptoms or a bad cold-like symptoms. So people tend to put these away. And once this gets to a point where it presents itself as a pneumonia or ARDS, that's a little bit, too harmful to the patient. So these symptoms are in no order, but definitely these are predominant symptoms we see in COVID-19 patients. The reason why I mentioned the pulse oximeter and the nausea and vomiting in highlighted things is there's a machine which is used in a doc's offices to measure your saturation percentage of your oxygen, which goes on your the finger, and they measure it. I have seen many recommendations with regards to it, and I have seen one of my patients who checked himself had a very low oxygen level in the higher 80s and upper 90s, and he was rushed to hospital, and by the grace of God, he pretty much survived. Although he was diabetic, he has heart condition and everything, but the doctors were able to help him come out of it. But the pulse oximeter really helped him to know exactly what his oxygen saturation percentage was. And the moment it falls below 95, you could see some problem in breathing, like a tightness in the chest or persistent cough. If anyone whom you know are experiencing this, I think it might be a very good idea to get tested to make sure they do not have the dreaded COVID-19. And if they do, it's good to get some medical intervention and see they can get over it. Initially, the success rates were all over the place, but I think for the past few months, we have seen a substantial progress in the patients who are infected with COVID-19 are being able to beat the disease and get back to their lives. So just keep in mind that if anybody whom you know gets corona or COVID-19, it's not the end of the world. It can be treated, and we have the hospitals and doctors who are very well qualified to handle this, the disease. So I know Lisa said that next week we have an epidemiologist from UConn able to tell us about more in detail about this, but I just want to give a brief idea as to what it is in terms of the epidemiology of the COVID-19. These numbers look, this is a little bit confusing, but let me go through a few of them superficially, and that way we can get an idea as to what exactly these mean. The basic reproduction number is like if a person gets infected with the coronavirus, the chance of him or her passing this disease to other people is 1:2.5. What it means, if a person gets the coronavirus or COVID-19, they can pretty much pass it on to 2.5 to 3 people, depending upon, it's not exact, but it's somewhat close to it. So, but what happens is it's not just, it doesn't stop there. It's 1:2.5, but the 2.5 people or 3 people over there then tend to pass it on to 2 to 3 more people. And that's where it becomes exponentially transmitted. And then we see the community-based disease spread. The overall symptomatic case fatality rate is at 0.4%, which means that people who have symptoms with the COVID-19 the fatality rate is at 0.4%, which is low. But again, at the same time, any number is definitely not welcome, especially when it comes to the life of people. The people with symptoms who are being hospitalized with this COVID-19 is at around 3.4%. So every 100 people who get infected with COVID-19, you have 3 to 4 people getting hospitalized to help them beat it or help them get additional support in breathing or ventilator or oxygen and stuff like that. This is the most thing about this COVID-19 is I'm sorry, let me see. Previous, okay. The asymptomatic infection rate is at 35%. That means out of 100 people who have COVID, 35 people are not having any symptoms. That means they would be absolutely normal. And this is very bad, and at the same time, it necessitates the need for wearing a mask, the right mask to help reduce the transmission of this dreaded disease. And the time of exposure, which means that from the time the person gets exposed to the COVID-19 to the time where the symptoms onset is anywhere between 2 to 14 days. But the mean or the median approximate time frame, which is set by the doctors, is around 6 days, 4 to 6 days. So if somebody is exposed to a COVID-19, one would expect to see the symptoms like the chills, the fever, the sore throat, and the fatigue or the flu-like symptoms come up within 6 days. The next subject is obviously once you have a COVID, what you're going to do. The testing. There are 2 different kinds of testing. One is called the diagnostic testing, which you test to see if a patient who has the symptoms or who is asymptomatic can get tested to see if they were exposed to somebody with COVID-19. The patient could get tested to see if they have the active viral infection in them. This is called the molecular or antigen testing. And there are two different kinds of these. We'll go to the one in the next slide, but this is called the molecular or antigen testing. And the next one, which is not recommended by the CDC, is the antibody testing, which means that when someone is exposed to coronavirus or COVID-19, the body creates antibodies to fight it, and that could be seen in the body or the blood of the patient, and that could be measured in this test called the serological test, which measures your antibodies. And there are different kinds of testing which would tell us if the infection happened recently or happened some time ago, based upon the kind of the antibody is there in the blood. On to the next slide. So in the diagnostic, the viral testing is done, which looks at either the nucleic acid, which means that in a cell there is something called as a nucleic acid. We call it DNA and RNA. To go deeper into it, it's called deoxyribonucleic acid and ribose nucleic acid. These are the ones which play an important role in how the coronavirus gets into the body and invades the cells, makes copies, and tries to infect the other cells. So we have two different kinds of testing, which is the rapid testing and the longer testing, which takes anywhere between a couple of days to I've seen the test results come back in a couple of days. So the other one is, as I said, the antibody testing. The common tests which are used is called IgG and IgM, and which is called immunoglobulin G and immunoglobulin M, which tells us about what kind of antibodies you have. And with that, one could be said that, okay, you have a recent exposure to coronavirus and your body fought it, or you had a while ago, maybe like 4 weeks ago or 5 weeks ago. And this antibody testing is definitely needed to know how many people got infected and what is the infection rate and how much of them are symptomatic, asymptomatic. All this data can be gotten with antibody testing. So although it's currently not the CDC recommended, but we see a lot of people getting these tests done at different places. So when in doubt, it's always recommended to talk to a healthcare professional and decide what's the right way. But if at any point, if you are or any of your loved ones are exposed to coronavirus, the best thing to get done is the testing done. And upon knowing there's no active infection, just continue to take the precautions. If exposed, just quarantine and try not to spread the disease, because it only makes life difficult for all of us. And now I'm sure every one of us have been hearing about everybody worried about what will life be when we have the flu season start in a couple of months. Generally, the flu season starts at the end of September, October, all the way through the following year, March, April. As I said in my initial introduction, that this COVID-19 mimics a lot of flu symptoms. So it's very, very hard to distinguish looking at the symptoms. But the only thing is, if you get a flu shot, what it does, it helps you protect from the flu. At least, if it's the flu, at least, you're protected, and you could probably get a little bit sick, but your body fights it off, and, you wouldn't have to endure all the pain that comes with the flu. On the other hand, COVID-19, could give, probably result in ARDS, pneumonia, and we have heard many healthcare you know, specialists talk about how this COVID-19 creates something called as your body responds to it in something called as cytokine storm, where your body attacks itself. And unfortunately, you know, the only way one could know if it's a flu or a COVID is by looking at the testing. And the flu is generally done with the same as the COVID, the nasopharyngeal, and the flu test is generally rapidly done, rapid flu test. The COVID also has a rapid test, but I think the longer one is much more. The detection rate is very high with the one with the longer return. So other than that, you know, it's as a pharmacist, I recommend everyone who has any pre-existing conditions or any other comorbidities to get the flu shot. It's as August is a national immunization month. So I recommend as a pharmacist, as a immunization pharmacist, I recommend everyone and have their loved one get the flu shot, which could protect us from the deadly flu. And also, if by continuing to use the mask and maintain the social distance, probably, you know, we could see less of a flu this year when we maintain that distance and try to have the, you know, the hygiene, the hand hygiene, and the you know, having the mask would probably protect a lot of us, the kids and the loved ones, from the flu, because, you know, we are distancing ourselves with the immediate infection or the, you know, the droplets which could be spread from the flu infection. Treatment options. We would love to hear what are the treatment options for this dreaded COVID-19. Unfortunately, there are no treatment options like a drug of choice for this. However, the Gilead drugs, which makes a lot of antiviral drugs, which makes a lot of HIV drugs and other drugs, came up with this drug called remdesivir, the first one, which is used for, which they tried to, they invented for the Ebola, but luckily the world was able to, you know, contain it, and it never got used on a, thankfully, never got used on the Ebola patients much in America. However, with the recent studies, you know, at different hospitals across America, we have seen that this drug has been helping patients to reduce the sickness duration, and also helped in different the positive outcomes in patients. The other drug, which I have not seen in America, however, I heard in Japan and other places, is the favipiravir, which was used for the flu in Japan and other Asian countries, has shown some degree of efficacy in those countries. Excuse me, talking for a while is giving me some sore throat, but I apologize for you know, setting my throat. Coming back to the next one is the dexamethasone. This drug has been there for decades. It's a very inexpensive drug. It's given many times when we see people going for an MRI or a CAT scan, where they get the dye into the blood, and we see this dexamethasone given to it, and its safety profile is very good. There are not many side effects, if not any, over the years and decades. And it's the best part, it's very inexpensive, and the outcomes have been phenomenal. It's very startling to hear that it reduced the deaths by 30% for patients who are on ventilators and supplemental oxygen, and it has decreased by 25%. These patients are the ones which are intubated with a ventilator, and they are in an induced coma and all these things. And having 30% success rate is phenomenal with this drug. And I'm sure a lot of us have heard about the immune-based therapy, which is getting the plasma from the COVID patient who beat the COVID and have the antibodies, take the antibodies and inject into the patients who are ill. I have seen a few of my patients get this plasma initially when, in the initial, like the April, May of this year. And the success rate was fairly decent. And I know 2 patients, and both of them got the plasma from the previously COVID infected patients, and both survived. And they were put briefly on a feeding tube, and eventually they came off the feeding tube, and now they are slowly getting back to their normal life. And these patients are the ones with diabetes and kidney issues. So these are promising therapies, treatment options, and we are in the country where we have the best medical care. With all the politics aside, I think, we have a very good healthcare. And coming from a country where I've seen, different, the healthcare, I can definitely say that the kind of healthcare we receive in this country is exceptionally good. And these therapies have also really decreased the fatalities in the COVID-19 patients. As we mentioned, this is a very novel coronavirus, so none of us knew about what this was, and everybody is learning as and how we are going through it. Unfortunately, it's coming with a price, but but nonetheless, this is a very the whole healthcare and the research community has been working phenomenally with the research, and I'm sure very shortly we should be having some degree of success, if not a major success, in this virus, because we have countries working together. As I said, the one thing this coronavirus did to the globe is bring us all together to work towards it, as opposed to being divisive. The other drugs which we have seen over the course of research are the ivermectin, famotidine, and montelukast. The ivermectin was a small study done in Australia, and nothing was done with regards to it, but the case study shows within 2 days, the viral load in the patient has gone down substantially. But I don't know why it did not, I cannot speak for it because my scope of knowledge is not that much when it comes to why it was not done. Famotidine, which is also used for acid reflux, just like the Zantac, it's called Pepcid. We have seen this use on a substantially higher doses, and it has given some degree of possible outcomes. But again, please do not use it without consultation with any healthcare provider, please. This can only be done, and only be done, I repeat myself, under the direction of a healthcare professional, namely a doctor, a hospital, or other people. And the montelukast is nothing but singular. We have seen kids and adults use it for different kinds of to prevent any kind of chest infections with asthma, other things. And the way it works is it's a leukotriene inhibitor. And with the coronavirus, we have seen an increased number of concentration of leukotrienes in the system. So a higher dose of singular, has seen some promise in New York and other places. However, please, these have to be given under the guidance of a healthcare provider, namely a doctor and an infectious disease doctor, but do not use it thinking that this is going to help you. It has to be under the direction of a doctor, and none of us who are hosting or presenting this presentation it's only for knowledge, not for recommendation. And last but not least, we are going into the vaccines. I know the whole world is running towards the vaccines. From what I gather from the internet, from Fast Cures and other institutes, is the different levels of this phases in this vaccines: phase 1, phase 2, phase 3, phase 4. The preclinical is the initial studies, what they do. The phase 1 is they have a very small group who are healthy people. And if you remember, initially we started doing it in the healthy volunteers up in Washington, in Oregon and the Washington State. We had a few initial volunteers who got the vaccine. And once they see the response in them, how the body builds the antibodies and other things, how they attack the virus, then it is given to a larger group who has other any kind of health issues to see what is the outcome, how the body is reacting. Is it able to create that kind of antibody response, which would stop the body from getting infected with coronavirus? These are closely monitored and read. And to give a brief idea, I registered myself to be a part of the phase 3, where they want to test the vaccine. And I volunteered with the Pfizer company to see how this helps with the patients. There are different kinds of vaccines, namely, it becomes a little bit more verbose and more intricate when it comes to what kind of vaccines, but different companies are working on different kinds of vaccines. Some companies are creating vaccines that create just the antibodies to fight the virus. Some companies are working on a vaccine which creates the antibodies and something else called T cells to fight the virus. And some companies are working on something called as a viral vectored vaccine. What it does is this is done by AstraZeneca, the makers of a lovely medication called Nexium. Those guys and the Oxford Health in UK, the United Kingdom, they are working on this one. So the different people are working in different ways to see what is the best possible outcome for this infection. So whichever works, I'm sure we will have the best possible product out there, and I'm sure the CDC and the FDA and everybody are working in sync to get the best one out there, so we can protect our loved ones and other the first line health workers and the vulnerable ones. In that way we don't have to live this life for a long time where we don't know what is infecting how. Unfortunately, at this point, there are no approved ones in America, although we come across the new from various outlets that there is a vaccine by Russia, which is approved. But again, the vaccines that can be given to the people in this country have to be approved by the FDA, and that's the only one which can be produced in a large scale and given to the people. So unfortunately, nothing has been approved as of now, but that I'm sure that will change very shortly, because we are already in the phase 3 of various vaccines, and that should be out soon. While I'm there, I just want to bring a brief idea as to how long it takes to bring the vaccine. The general time frame which a vaccine takes to come into the public is approximately 10 to 11 years. So, and this COVID-19 happened to us in the world last year towards November, December in China, and eventually came to America, in January, February. We are in August right now, and we are at the phase 3. So you can see how well this research has been going across the globe to make sure that we have a vaccine which is able to produce some at least 50 to 60% of immunity to the COVID-19, which can be termed a success. So with just to give an idea, the polio vaccine took 7 years. The measles took 9 years. The chickenpox took 34 years. The mumps took 4 years. And the HPV vaccine, the Gardasil, took 15 years. And this coronavirus vaccine is getting towards hopefully the finish line in about 8 to 10 months. So now we can understand how difficult it is to create a vaccine which is good across the board. But as with the treatments and the outcomes and we will be learning as and how we go through it. And the safety and efficacy will be very well monitored by the FDA and the CDC to make sure it can be given to a large population before they roll this out. With that being said, I apologize for this extended long presentation, but I'm open for questions. Hopefully I can answer if you have questions, and and I turn the mic over to Nilda and Lisa.
Yes, thank you. Thank you. Excellent presentation, Lex. I have a few questions. We're going to try to go over these few questions that the attendees have as quickly we can because the time is running. So the first question was in relation to the case you were talking about, the OTC level. There's a lady here that wants to know how low was his oxygen level.
From what I heard from the family members,
yes,
it was approximately at 88%. So he was diagnosed with something called as ARDS, acute respiratory distress syndrome, where your lungs cannot breathe by themselves. They have to be on external help like oxygen or a ventilator. In this case, the patient was put on initially in oxygen and eventually went on ventilator for 25 days and came back out of ventilator and got discharged in the hospital after 2 months.
Okay, thank you.
This is Lisa. Can I just ask one quick question though?
Yes.
That was one situation, but would it be the case for everybody, or if somebody finds that their oxygen is in the high 80s, can they maybe not necessarily need a ventilator?
Okay, Lisa. I mean, this is one of the cases I encountered, so I should not be speaking on a general population.
Right.
But what is recommended is anytime you see your oxygen level below 95%, and please don't quote me on this one, this is what I gather from talking to different healthcare providers, less than 95%, you should be in contact with the healthcare provider and get monitored to make sure there's no something underlying condition where it is stopping your oxygen saturation level to be at 99% or more.
Thank you. Thanks a lot.
You're welcome. You're welcome.
Thank you. I have a case here where a person have a few comorbidity issues, and she want to know, she just exposed this case that her daughter and her husband and an 8-year-old son are coming over the week for visit me next week, and they have been careful with mask and distancing, but not isolating. They will isolate for a few days before being arriving. Should they get texted before they come over, and what precautions should I take because I have these comorbidity issues?
Great question, Nilda. The only way we would know if somebody has the COVID is only by the testing. And fortunately, it's free. So to protect our loved ones, our friends and family, you have to be at utmost careful. A mask is helpful, social distancing is helpful. However, we do not know for sure. And you don't want somebody whom you love to get infected with this dreadful disease because as I said, 35 to 40% patients are asymptomatic. That means you absolutely have no symptoms. And with the ACs running in the house, with the hot climate, people jumping in the pool and everything, many people could have a scratchy throat, a sniffle, something or the other, and we don't know if it's really a COVID or from these exposure. See, the only thing I would recommend as a healthcare provider is just get tested to make sure they do not have the corona. And I'm sure if they are negative, just quarantine themselves, not to get exposed to other people and come visit you. Because kids and the healthy adults, the hospitalizations are at very minimal. But when it comes to elderly and comorbidities, it's much higher. So you have to be careful than sorry.
Thank you. Thank you, Les. The next question is if this slide presentation will be available for us to send out to the attendees.
I would leave that to Lisa. What I would do is I will, before we send it to everybody, I will make sure that each slide has the reference where we got the information from. So we are in compliance with the copyright laws and everything. As much as I try to quote at the bottom where the source of the information was. But yeah, definitely we would be more than happy to provide this and any of the handouts as needed. And then I will provide that to Lisa, and Lisa will be more than happy to, upon her discretion, she'll be more than happy to provide it to the attendees request.
Perfect, awesome. I have a parent here that asked, since they've been talking to returning to the school. She asked what you think about to returning to the school or be open again. What kind of advice you can give the parents?
I have two daughters who are 6 years old and 8 years old, and I'm sending them to school. What they say is from the recent studies and everything, in kids, we do not see major side effects. I mean, like the symptoms. If anything, they will get a mild cough and cold or a flu-like symptom for a couple of days, and they are able to bounce back. But that doesn't mean that they cannot pass it on to the elderly or the family members. So having them wear the mask and maintain that social distance in the school is very hard, especially with the kids. But, I'm sure that the teachers and the school, administrators are doing their best to, follow the guidelines from the state Department of Health and the CDC to minimize the exposure. I know from what I see from the New Haven and Bridgeport, as of now, are at distance learning, but the other places have different schedules where some kids are going a few days, some kids are going other days. So the social distance is maintained and the exposure is limited. Is it foolproof? Honestly, no. But all we can do is mitigate or minimize the exposure. And I think all these programs which are put in place by the DPH and other regulatory and the agencies are pretty sufficient, and will protect the kids and the teachers.
Okay, thank you. There's another question here that says, how long do the antibodies protect you for if you have had COVID-19?
Thank you for the question. There's been a lot of research going on as to how long this would protect people. Some studies are saying anywhere between 3 to 6 months, and some are saying longer. One study that was done, and the people who got reinfected in China, especially in the places where it was originated, in Wuhan, the second time they got the COVID, their symptoms were very mild, if any, and they got over it. So it doesn't mean that it is across the board, or we can paint with a broad brush, but from the limited data we have, the second time infection is minimal, and it's been very with little symptoms and not that concerning. But again, it's a very small sample size. Okay, thank you. And the last question that I have here is how the Montelukast, the singular
help? Is as a prevention or as a treatment?
Again, I just want to make sure it is not a treatment, it's not a prevention, but if a patient has been prescribed Singulair, that is because they have an underlying condition of asthma, and it helps with the inflammation of the windpipe, and this Singulair helps with that. And people with asthma who get infected with COVID-19 have far worse outcomes as opposed to people with no asthma. The same thing holds good for people with diabetes. So if a patient has been prescribed the Singulair, it's recommended that they continue that, but not overuse it. And as I said, this was a small study done in New York, and they said that they've seen some degree of efficacy, but it hasn't been the protocol to treat the patients. So it's not something to prevent or something to treat, but something you should be taking if you are diagnosed with asthma and to protect yourself better. That's the best I would say.
Thank you. I appreciate Lex. If anybody have any other question, Lisa?
No, there are no new questions here. One last call out to you guys. Does anybody who's out there in our audience have any questions that they would like to ask Lax?
Yes.
Okay, hearing nothing but my cat, I'm going to presume that we have answered everybody's question. I want to thank you all very, very much for attending this. We will be sending out a copy of the presentation within the next few days. We will also send out a questionnaire asking about your feelings on the presentation itself. I want to just remind everybody that we do have an epidemiologist and infectious disease specialist who will be speaking next week on Thursday. The invitations will go out, same time, different week. And I also want to mention that we have a speaker from the Sepsis Alliance who will be joining us sometime during September, which is Sepsis Awareness Month. And they will be talking about the intersection of sepsis and COVID-19. There are tremendous relationships between the two, similarities and some substantial differences. So they will be trying to clarify that all and making us more aware, all of us, about sepsis, which is unfortunately one of the most prevalent reasons for readmissions into the hospital. And